Yay, good morning, everybody. Eva, maybe you should get started because we're going to be finishing at 7:45. And thank you, Dr. Saad.
Of course, my pleasure.
Okay, so yeah, the first case. So the first case, this is a 73-year-old female who initially presented to ENT for progressive hearing loss for about 4 years, and as well as imbalance for 1 week. She had no other relevant past medical history. The only thing significant on her exam was a mild upgaze palsy. And so I guess, let me see who's on. Okay, so I guess Turkey, what do you see in this MRI and what sequence is this?
Yeah, so this is an MRI, T1 without contrast. I can see that there is a probably like pineal mass with some hydro. I would say like posterior fossa mass can be seen best on the middle axial MRI.
Are there any other sequences you want to get or any other scans that you want to get?
For sure, would love to get MRI with contrast, T1 with contrast, and T2 as well.
Okay, yeah, so this is the T1 and with contrast and T2. So what do you see here now?
Yeah, so this is more apparent. I see heterogeneous lesion that is also, has some areas of contrast enhancing pineal in location, and also the hydrocephalus. On T2, I can see that it's hyperintense, probably hypercellular in origin.
Yeah, exactly. So based on this lesion and what you see, what do you think would be your differential diagnosis?
I would say that number one would be, given the age, could be a pineal origin tumor such as, pineocytoma, pineoblastoma. I don't see any calcification, so less likely pineoblastoma. Germ cell tumor, more in children, but I would include that as differential. Could be also non-pineal tumors such as either astrocytoma and less likely meningioma. So these three type of tumors that I would think of in this location.
Yeah, exactly. So basically, like what you said, there's the main pineal, parenchymal tumors. And so, like what you were saying for pineocytoma, the only thing I would add is, it's WHO grade 1, and then this pineoblastoma is WHO grade 4, and pineal tumor of intermediate differentiation that kind of classifies the tumors in between those grade 1s and grade 4s. And for the germ cell tumors, the only thing I would add is, you could have either germinoma or non-germinomatous germ cell tumors, which those include like the yolk sac tumors, embryonal carcinoma, choriocarcinoma, and also teratomas, and then the other category, like you said. And so based on this, what is the next step? Like, what would you do for this patient?
Yeah, so my approach to this lesion would be supracerebellar imperatorial approach. But
is there something else you would do before surgery though? For pineal?
Yeah, I would do whole spine MRI to make sure there's like no spine mets. And also if it's germ cell, I would do blood markers such as alpha fetoprotein, beta CD2 in the blood.
Yeah. So, you have to send the germ cell markers like what you said. So the thing, if the germ cell markers are positive, what would you do?
Then, I would lean more toward, germ cell tumor, and they are more responsive to radiation therapy.
Yeah, exactly. And so then what if it's negative?
And if it's negative, then I would definitely do surgery, at least, get a diagnosis and then proceed.
Yeah, exactly. So, for this patient, the markers are negative, so what is your main goal of surgery other than, to get tissue diagnosis?
To decompress because, the patient has hydro. And, this needs to be taken out to alleviate the pressure and restore the circulation to CSF. So, and also to prevent recurrence of the mass.
Yeah, exactly. And so what would your, plan for surgery be? Like you were kind of talking about it a little bit earlier.
Yeah. So the first approach is supracerebellar infratentorial approach, but given that he has a steep, tentorium, I'm leaning more towards, transtentorial, occipital transtentorial approach in this patient.
Yeah.
Also,
Go ahead. Yeah.
Also, you can do intrahemispheric approach, but that's a very long track. So that's my least likely approach.
Yeah. So like what you were saying about the tentorium being steep, sometimes other people say that you can do a lateral, like a paramedian super tentorial or supracerebellar infratentorial, just because if you see on, I don't know if you can see my mouse, but on the coronal slice, it's like here where the pineal region is, the tentorium's pretty steep, but as it goes out here and on the sagittal on the bottom, the tentorium kind of starts sloping down. And so sometimes you can still get it from, paramedian approach. But with this, the thing is that they ended up doing an occipital transtentorial because the torcula is very low. And so it would just be hard to get that angle. And so that's why, they did an occipital transtentorial. And they ended up coming from the right just because the lesion was more eccentric to the right. And, you can see here their craniotomy, it just extended, past the sagittal sinus, and then they went interhemispheric. Okay, so we'll turn it over to Dr. Saad for the pathology.
If it's okay, let me share my screen, please. Okay, good morning, everyone. So this is the tumor. This is the intraoperative smear that we do to assess the morphology. And as you guys mentioned, this is a very cellular tumor. We put it under the category of blue cell tumors, meaning the tumor cells have very scant cytoplasm and they're rich in chromatin. These are the histologic sections. So this tumor has two distinct morphologies. This is the first one, which I'm showing you. You can appreciate the presence of this monotony of tumor cells, and also some tumor cells have a clear cytoplasm. This is the second pattern where the tumor cells are packed together, but it's very rich in vessels. By immunohistochemistry, neurofilament is diffusely positive, which support the diagnosis of a primary pineal tumor. And synaptophysin is another supportive stain that is diffusely positive. Ki67 is high, reaching about 15% in some areas. So this is a pineal parenchymal tumor of intermediate differentiation. The jury is still out in terms of what grade this tumor corresponds to, 2 or 3, but the defined histologic features are not out yet. So depending on how the tumor behaves and the imaging studies, you can call it grade 2 or grade 3.
Okay, so let me share my screen again. Give me 1 second. So like Dr. Saad said, this was a pineal parenchymal tumor of intermediate differentiation. It's usually WHO grade 2 or 3. And so these tumors arise from the pineocytes, and it was actually added to the WHO classification in 2007 because initially they had just 2 categories of pineal parenchymal tumors, and it was just this grade 1 pineocytoma and this grade 4 pineoblastoma. And so to categorize those tumors that were in between those grades, they added this this classification. And so usually occurs in adults 20 to 70 years old. And so this just kind of gives it's just a chart to tell you, the incidence of all these different pineal tumors and what's most common. And so the most common is germinoma. And then these pineal parenchymal tumors just make up a very small amount of these pineal region tumors. And so guess who's on? Sumed. if I ask you and give you these three MRIs, which one would you say this is pineocytoma, pineal tumor of intermediate differentiation, or ependymoma? Like which one of these three is which? Sumed there? Or maybe Damien?
I'm here, but I can't see the screen.
Oh,
It's just like, there we go.
are you able to see the screen now?
Yeah,
or-
I can see it now. So which one is which is what you're saying?
Yeah.
I would say pineocytoma would be the I don't know, like the
I guess
first one
it's-
in there. Yeah, it's kind of.
So I guess
Should be
it's
honest, but-
the point of this is it'd be kind of hard to tell. I mean, they all look kind of similar, right?
Yeah.
And so, they're all on T1, non-contrast enhancing. They're kind of in the same region. They look, almost the same, like nodular appearance. And then on T1 with contrast, it's, contrast enhancing. So all it looks pretty much the same. And so the point of this slide is just basically to say that, just basing it off on radiographic characteristics isn't going to, makes it difficult to tell exactly, what type of lesion it is. And so you really need tissue diagnosis and, base it on histology. And so now if I give you the slide and I ask you, which one of these three is the first one, with the one with like sheets of tumor with bland nuclear features, what would you say? Similar to what Dr. Saad just said.
That's the intermediate, like intermediate differentiation.
Yeah, and then Victor, what would you say is the this, if I gave you this one with pineocytomatous rosettes with these like tumor cells and their neuropils kind of forming towards the center, what would you say this one is?
The cytoma.
Yeah, exactly. And so this is, differentiated from this ependymoma, which has these perivascular pseudo rosettes. And so that's, it has these like capillary and vascular structures in the middle with these tumor cells forming around it and kind of putting their neuropils towards it. And so that's what's different between these pineocytomatous rosettes versus these perivascular pseudo rosettes. Okay, and so second case, this is a 36-year-old female with headache and imbalance for 1 week and, no relevant past medical history. On exam, she's intact except for dysmetria with a finger to nose. So long, where do you expect this, lesion to be based on the history? Is long there? Or maybe Emad? Or Tyler Cardinal? Okay, what about Adam?
Yeah, Cervical.
Okay, yeah, exactly. So, so on this MRI, tell me what sequences you see and describe the MRI.
Yeah, so you see here, and that's the CPA angle on the top right one, on the coronal section, you see a cystic lesion with a contrast, minimally enhancing lesion as well. Most likely in my differential, this would be like a CPA angle tumor, maybe a pilocytic astrocytoma.
Okay, good. And so would you think that this is diffusion restricting or no?
You're saying, is there a shift? Is that what you're saying?
Does it restrict diffusion on these lower tier images?
I see some restriction here with, I don't know if it's a T2 like shine through, more than restriction.
So I guess we can call on, let's see, David, you know how to differentiate, T2 shine through from diffusion restriction?
Yeah, I mean, if you look at the DWI sequence, there's restriction on the bottom right there. And then in the middle, it like in C substrates, there's I7 heads,
Mm-hmm.
and they're distinct between the DWI.
Mm-hmm. Yeah. So, so usually if it's like T2 shine through, this part will be bright as well, along with the this ADC will be bright, and on DWI it'll be bright instead of being opposite. And so yeah, like what Adam said, this is a cystic lesion with a mural nodule that's heterogeneously enhancing. Looks like there's also this fluid level, and it restricts diffusion. And so so Adam, you mentioned kind of one differential so this is an adult patient. What would be one of the other differentials? Adam, are you still there?
Yep. So we're looking at for adults for CPA angles. We could consider a meningioma. We could have considered a schwannoma. We could also we said pilocytic astrocytomas. I think those are the 3 highly differentials for adults. If it was a peds, then I would have a different differential for them as well.
Mm-hmm. So let's see, David, do you know what is the most common like cystic posterior fossa lesion for adults?
Epidermoid.
Okay, what about Sumed? What is the most common cystic posterior fossa lesion for adults?
Yeah,
Sumed?
sorry. So the most common cystic lesion for adults.
Mm-hmm. For in like the posterior fossa.
Posterior fossa. I would still say like a JPA. I know it's like juvenile, but pilocytic astrocytoma or metastasis.
Mm-hmm. Okay, so yeah, so more for kids, JPA, but for adults, the most common is medulloblastoma, actually, and then like medulloblastoma is not usually a cystic, and then metastasis, and for kids, the most common is actually medulloblastoma, and so it's the opposite, and so then pilocytic astrocytoma is less common than medullo, and then for hemangioblastoma, it's the least common unless the kid has VHL, and so that's what's different than adults. And so the main thing also is that for adults, these hemangioblastomas and these medulloblastomas, they occur in the cerebral hemisphere, or the cerebellar hemisphere. And for children, the pilocytic astrocytoma is also in the cerebellar hemisphere, but the medulloblastomas are in the midline, the vermis. Okay. And so let's see. Let me see who I can call. Or I guess, Damien, what would your approach be for this? And would you do surgery? What would you do?
Yeah, I think, there's stuff, compression at the brain stem, pretty large lesion. I think surgery is the most reasonable option. And so as far as approach, generally to get to the CP angle, I think the most common approach is going to be a retrosig, a left-sided retrosig. It's all under the tentorium, so I think that's
yeah, exactly,
probably the most reasonable option.
Yep, so that's what they did. So we'll turn it over to Dr. Saad for the pathology.
Okay, thank you. Okay, so this is the tumor. This is another high-grade blue cell tumor. You can appreciate the presence of a couple of mitoses. This is one, and there is another one. And also there is significant atypia and pleomorphism. And one of the characteristic features of blue cell tumor is that these cells tend to hug each other. We call it nuclear molding in pathology because the nucleus is very soft owing to the presence of increased number of chromatin. This is at lower magnification. You can see the tumor that is sheet-like growth with no particular growth pattern to suggest any particular differentiation, which is characteristic of undifferentiated blue cell tumor. However, the tumor cell is are negative for pittacatinin. Ki67 is very high, approaching 80% in some areas. Synaptophysin is weakly positive. I just got the result of MIC and is negative, so it's not amplified. So this is a medulloblastoma grade 4.
Yeah. So let me share my slide again. Okay, so as Dr. Assad said, this is a medulloblastoma who grade 4, and so it's more common in children than adults, and in adults it's actually really rare. And so with medulloblastoma, they arise from these embryonal cells, and there's 4 different cell types: the WNT, the SHH, and group 3 and group 4. And these different subtypes, it all depends on the cell of origin. And so you can see here on the right, where the cell arise is where is the subtype that they are. And so most commonly it's from a loss of 17p. And so there's actually 5 main histological subtypes of medulloblastoma, but here are just the 3 more common ones that we'll talk about. And so for the classic ones, that's the one that you see on the step and the boards, is these sheets of small round blue cells, and so that's why they call it the small round blue cell tumor. And then the middle, it's the nodular and desmoplastic variant, and so that's kind of self-explanatory. You see these round pale nodules of tumor that are separated by these darker zones of tumor, and so this is actually a better prognosis. And then for the last one, it's a large cell anaplastic, and so you see these large cells with these vesicular nuclei, and so this is actually highly aggressive and worst prognosis of these 3. And so the medulloblastoma, they're also categorized into these molecular variants that we talked about earlier based on where they arise from. And so with these molecular variants, what you need to know for the boards is they usually ask what is the best prognosis. So that one would be the WNT subgroup, and the worst one would be the group 3 subtype. And so then group 4 and SHH are intermediate prognosis. Unless you're an infant, then the SHH subtype is actually a good prognosis. And so we'll ask maybe David, if I gave you the same exact image as the same MRI from before, and I give you this histology slide, what would you say this lesion is?
It resembles more like a hemangioblastoma.
Okay, yeah, so this you see these here, these are actually Rosenthal fibers, and so here this is characteristic appearance of pilocytic astrocytoma. And so this is again more common in children than in adults. And so we'll ask maybe Sumed, if I give you the same exact MRI and you see this histology slide, what would
Yeah, I think if you gave me that image, I'm looking at what I see blood vessels there. So I'd say that's a hemangioblastoma.
Yeah, exactly. So so usually it has these capillary structures surrounded by these stromal cells, and so it's hemangioblastoma, and this is more common in adults than children unless they have VHL. Okay, and so this is the next case. It's a 65-year-old man who presented to the ER after a syncopal fall while he was at work. No other significant past medical history. He's intact on exam except for a slight hemiparesis in the right upper extremity, 4 out of 5 strength. And so we'll call on Long. What do you what would you do? Are you there, Long?
Hi, sorry, yeah. I would like some imaging.
Okay, what would you get?
I would start off with a CT head first.
Okay, good. So okay, here's a CT. What do you see?
I see on the left, so there's an axial with a sagittal CT head non-contrast. Left side shows some hyperdensity in the subcortical white matter. There's some sulcal effacement suggestive of some edema. I would follow up with an MRI.
Do you see anything else on the right side, or I mean the left side?
There's some mass effects, maybe some slight midline shifts.
Mhm.
There are some like punctate hyperdensities on the left in the frontal, kind of frontal lobe.
Mhm. So what imaging, would you get into other imaging, or what would you do after this?
Yeah, I would still follow up with the MRI.
Okay, yeah, so here's the MRI. Tell me what sequence this is and what do you see?
Yeah, so this is an axial coronal sagittal T1 with contrast. I see a left contrast enhancing lesion in the left frontal lobe with some significant vasogenic edema. There also appears to be contrast enhancing lesions in the right frontal, and then also another lesion inferior left frontal lobe as well.
Yeah, exactly. And so is there any, I guess, Emad, is there any other sequences that you would want to see when you see these, ring enhancing lesions?
I probably also want to see like a flare sequence, just to kind of get a better idea of how much edema there is.
And what is there another sequence you would want?
A DTI.
Yeah, like DWI ADC. And so here you see this. I guess we can go to Tyler. Do you think that this is a diffusion restricting?
Yes.
Yes, it looks like it's diffusion restricting.
Yeah. So here, it's looks like it's a little bit of diffusion restriction in the contrast enhancing region from before on the slide, and the central portion is non-diffusion restricting. And so we'll stay with you, Tyler. So what do you think the differential is when you see these like ring enhancing, lesions?
So ring enhancing,
6 main ones.
Okay. So there's like abscess, glioblastoma, metastasis. There's like demyelinating lesions, right? Is it cystic lesions?
Yeah. So that's pretty good. That's you almost got all of them. So the only other one was this lymphoma, and so here just shows the different types of ring enhancing lesions, and they all are ring enhancing and look kind of similar, except they have a little bit of difference in how they on imaging. And so with GBM, they have this thick Dr. Heroes always says it's like thick irregular borders that you see here on the left, and then it's then on abscesses, they have usually like a thin border with, and it's more regular than with GBM that you see on the left. And then with tumefactive MS, they have like incomplete ring enhancement like you see on the right. And so the other thing with the DWI ADC is that with these abscesses, they actually diffusion restrict centrally, but with like GBMs and METs, they only diffusion restrict on the periphery, and it's because usually the center portion is like necrotic, and so that's why it doesn't diffusion restrict. And so we can jump to, I guess, Victor. What would you do? Would you do surgery? Would you get all 3 lesions, or what would you do?
Well, you would need diagnostic tissue, but in addition to that, you would the left frontal, the most dominant lesion is a very accessible location, and so you could aim for a total maximal safe resection of the left frontal lesion with the intent of also achieving diagnosis from tissue.
Would you go for this other lesion on the right?
I don't know if you'd cross hemispheres, but you could, if there is intraoperatively any sort of connection between the large left frontal and that small inferior lesion as well, maybe you could go for that as well.
And so, yeah, that's what they did. They ended up doing this awake left frontal craniotomy, and they didn't get the lesion that's on the right. Okay, so we'll turn it over to Dr. Saad for path.
Thank you. Okay, so this is a glioblastoma, and it shows all the histologic features that you'd see in a glioblastoma. First of all, this is a malignant proliferation of astrocytes, and you have one mitosis here. So we are already in the high-grade category. In addition to that, there's a lot of vascular proliferation. This is the type of vascular proliferation that is commonly seen in glioblastomas. It is called glomeruloid. It looks like a glomerulus. Of course, the background is filled with highly malignant astrocytic proliferation, and this is the pseudopalisading necrosis. You have the necrotic center here, and tumor cells are kind of lined up at the periphery. By immunostain, the tumor cells are negative for IDH1. OLIC2 is positive, not in every single cell. We call it patchy positivity, which is characteristic of astrocytic differentiation. And GFAP is also diffusely positive. So this is a glioblastoma grade 4 IDH wild type.
So let me share my slide again. So yeah, this is this patient, because he had all these three separate different lesions, probably multifocal GBM, and so it's WHO grade 4. So there's for GBM, they usually you can have a primary or secondary GBM, and so with primary it arises de novo, versus for secondary it progresses from the low-grade astrocytoma or an anaplastic astrocytoma to GBM, and so that's why they call it secondary. And so, these two are difficult to distinguish histologically, but they differ based on their, genetic and epigenetic profiles. And so here on the right, it just basically shows that primary GBM is more common. It occurs in about 90%. It occurs more in older patients than the secondary GBMs, and they actually have a worse prognosis than with secondary GBMs. And usually for secondary GBMs, they occur more in the frontal lobe. And so here, this is just the kind of shows how they classify primary and secondary GBMs based on their mutation. And so with these primary GBMs, they don't have the IDH mutation, and they're non-MGMT methylated. And with these secondary GBMs, they usually have this IDH mutation and are MGM methylated. And so just to kind of talk about what Mgm promoter methylation is it's so MGMT that repairs like DNA alkylation. And so when you have methylation of promoters, it binds the DNA. And so there's a decrease in the ability of the cell to make these enzymes. And so when you methylate this promoter, it actually decreases the ability of the cell to repair DNA. And so when you have these alkylating agents like temozolomide, which we use to treat GBM, it produces damage to DNA by adding these alkyl groups. And so tumors that have this hypermethylation of MGMT have less of an ability to repair the DNA, and so therefore they're more susceptible to alkylating agents. And so the important thing to remember for the boards is that the MGMT hypermethylation is actually a good prognosis. And so for IDH mutation, wild type is the normal, and the mutant cells usually have this IDH mutation. And so IDH mutation confers a better prognosis than the wild type. And so this just kind of goes over what we just talked about. And so with these IDH, if you have IDH mutation and this DNA methylation, you have the best survival, versus if you have this IDH wild type and no DNA methylation, then it's poor shortest survival. Okay, and so this is our last case. A 40-year-old man with a headache and imbalance for a month. No relevant past medical history. Otherwise, he's intact except for some slight weakness. But that's just from, he had a fall, and so he had that weakness. So we'll ask, I guess, Imad, what would you do?
So I'd start with a CT head.
Okay, so they ended up not getting a CT head because they were in the ER. They decided to do an MRI instead. And so here's what the MRI shows. Tell me, what sequence you see and describe what you see.
So I'm looking at an axial cut, T2, T1 post, and see some signal intensity around on the right, say midbrain. It's not contrast enhancing, but there is some. It's bright on T2. Makes me think it's like fluid, probably just extension of CSF.
Yep. And so, I guess what other sequence would you get when you see this?
Perhaps like a DWI or T2 flare.
Yeah. So here's the DWI. What do you see?
So there does not appear to be any sort of this diffusion restriction surrounding the lesion.
So here, if you see on the left here, there's actually, diffusion restriction because you see here, it's like bright compared, so the brain itself is, this dark color, but then here, where the lesion was, it's bright. And so that's, diffusion restriction, it's not T2 shine through because on this right side with the ADC, it's not also bright, it's kind of iso intense to the brain. You see that, Long?
Oh, I see. Yeah, thank you.
And so what do you think is the differential Victor?
Primarily epidermoid.
Okay. And what else would you think?
I guess you can't rule out other types of tumors. In this case, it's very cystic and with restriction. Very unlikely, but maybe lymphoma as well as metastasis. Yeah.
So I guess you could also include like dermoids, and it's not really as much arachnoid cyst. And so just to go over the differentials, I guess we'll ask Tyler. What do you see here? What do you think is differential, or what do you think this lesion is?
So this is the T1 on the far left. It looks like is that with contrast? I can't tell. But it's not bright, and on T2 it's like same. It's bright on T2. Oh, and then okay, that's T1 with contrast, and it's not enhancing. I'm confused. And then that's diffusion restriction on the far right. And it's dark.
So here, I guess the main thing is, here it looks like you can see that it all follow like this little area in the middle cranial fossa follows CSF on all sequences, right? So the one is on the left is non-contrast, one on the second one is T2 and also follows CSF, and then one here on the third one is flare, and then here's DWI, doesn't diffusion restrict, and so if it follows CSF on all sequences, it's an arachnoid cyst. Okay, and so here comparison with this, I guess we'll go to Damien. What do you think that this is?
So this obviously does not follow CSF on all sequences. It's looks actually calcified, given that it's dark on, or sorry, not calcified. It's dark on CT. On T1 without, it's hyper intense, and then on T2 and flare, it's bright on T2 and darker on flare.
So this right one is actually like, so I guess if you look at the T1, like where you're saying, if it's bright on T1, what are the possibilities, like the 5 things that it could be if it's bright on T1?
Could be fat, could be blood, could be like melanin type lesion.
Yeah, and then or like gadolinium, and then just like proteinaceous stuff. And so here, you know, on CT, it's dark on, it's dark on CT and bright on T1, so it's most likely like you know, like fat can cause that. But so this is a dermoid cyst, and so with dermoid cysts, they occur in the midline, and they have these epidermal and dermal appendages. And so the dermal appendages include like sweat and sebaceous glands, and with these sebaceous glands, they actually secrete sebum, and so that's why you see this characteristic appearance on the MRI and the CT, where it's like bright on T1 and you know, hypodense on CT. And so here on the right, the main thing is with dermoid cyst, if you have, it'll be bright on T1 and then, you know, hypodense on CT, but then also here on the right is the flare with fat suppression, which is kind of hard to tell, but you know, it's fat suppressed because on this, if you look at the second image, you'll see the fat, you know, it's bright on the skin. And then here on the skin, it's not bright. And so here, this is fat suppressed flare. And so with dermoid, it'll suppress with fat suppression. And so I guess we can go to Adam, you know, what would you do for this patient? What approach would you do?
I would go a sigmoid or retromesoid approach for him, where I try to get a gross resection.
Yeah. So we'll turn it over to Dr. Saad for the path.
Okay, thank you very much. Okay, so this is the tumor. As you see multiple fragments of the cyst. So this is the inner surface. This is the lumen of the cyst, and this is the outer surface. I'll show you higher magnification. So again, this is the outer surface. As Dr. Wu mentioned, since there are no skin appendages on the outer surface of the wall, therefore it is not a dermoid cyst, but rather epidermoid cyst. And the lumen of the cavity of the cyst is packed with keratinous debris. So this is epidermoid cyst.
Okay, so with epidermoid cysts, you know, they arise basically because of an accidental inclusion of the ectodermal elements during neural tube closure. And so, you know, very rarely is it, you know, from iatrogenically, like post-surgically or post-traumatic, when you have, you know, epidermoid cells that are, or epidermal cells that are implanted. The main difference between dermoid and epidermoid is for epidermoid, it only contains these dermal elements like what Dr. Saad was talking about, and it's usually located laterally versus the dermoids, which are midline. And so they're very slow growing. And so that's why they present in, you know, 20 to 40-year-old patients. And so, what is the typical appearance intra-op of epidermoid cyst, David?
Sorry, can you repeat your question?
What's the typical appearance of like an epidermoid cyst, like the classic, you know, way that they describe, you know, when you see an epidermoid cyst, what does it look like intra-op?
It's like pearly.
Yeah, exactly. So it's like this pearly white appearance is usually what they say. Okay, and so do you know if this patient has meningitis, you know, after their surgery, what do they call that? There's like a particular eponym?
Aseptic or chemical meningitis.
Is there like an eponym that you can remember?
Not sure.
Okay, so it's like Molaris Meningitis. So with Molaris Meningitis, it's an idiopathic recurrent meningitis. And so usually has on the CSF, you have polymorphonuclear pleocytosis and presence of epithelial and you know, or endothelial cells. And the key thing is that with Molaris meningitis, it has to be recurrent. And if you just have one single episode of aseptic meningitis, it doesn't count as Molaris. And so, HSV2 is the most commonly found agent. And so what is the treatment for Molaris? Do you know?
Steroids?
Yeah, exactly. So, yeah, with steroids. And so now, the patient, after the surgery, if they improve and then all of a sudden, they start developing recurrent or rapidly progressive neurological signs and symptoms, and you see on this, you get an MRI and you see now this contrast enhancing lesion, and you see on histology after you biopsy it that it's, after you go to the OR, that you have this keratinization and these like atypical cells. What do you think is the diagnosis now, Damien?
It's transformed into like a higher grade lesion.
Yeah, so usually, if you see this, it's these epidermoids can actually transform into squamous cells. So that's what, sometimes they'll ask on. Yeah, and then I think that's it. So this is the references, and I guess we have a sub-I presentation, so we'll let the sub-I start.
Okay, thank you.
Great job, Beva. Thank you for transitioning to the sub-Is. Thank you, Dr. Saad.
Thank you, everyone. Bye-bye.
Hello, everyone. I will begin to share my screen. Okay. Hello, everyone. My name is David Matijek. I'm a fourth-year medical student here at the University of Miami. I'd like to thank you all for allowing me to speak today and for this opportunity to discuss my research entitled Patient-Reported Outcomes Measurement Information System, Physical Function, Validation for Use in Anterior Cervical Dissecting Infusion, a 2-year follow-up study. So anterior cervical dissecting infusion, or ACDF, is a common treatment option for cervical myelopathy and radiculopathy secondary to cervical spondylosis, which is a multifactorial age-related degenerative condition characterized by disc protrusion, osteotype formation, and ligamentous changes, including hypertrophy, calcification, and ossification. So the risks and complications associated with this procedure include dysphagia, pseudoarthrosis, recurrent laryngeal nerve palsy, adjacent segmental disease, and pain exacerbation. But despite the low complication rates and the ability to correct the anatomy surgically, the spine patient often requires a more holistic and patient-centered approach to assess true outcomes and change in disease burden. So one of the first advocates for the patient-centered approach in medicine was Dr. William Osler. He was one of the first to incorporate bedside clinical training into the medical school curriculum. And one of his more famous quotes reads, "The good physician treats the disease. The great physician treats the patient who has the disease." So I believe that this quote is particularly relevant in the field of spinal surgery, where an understanding of the patient experience is vital to surgical decision-making and the delivery of positive outcomes. So in order to incorporate this patient-centered approach into the clinical assessment, clinical questionnaires, or PROMs, were developed in the early 2000s. So these are clinical tools used to integrate patient perspective into the assessment of disease burden, need for intervention, success of treatment, and quality of life improvement. So PROMs fall into 3 separate categories: generic, disease-specific, and regional. And when combined together, they offer the ability to really extend the history-taking process and really give a lot of insight to the clinician as to the disease burden of the patient. So with PROMs, we hope to objectively measure the patient experience and track this information over time. Also, we would like to facilitate shared decision-making and improve healthcare value. So Dr. Michael Porter at Harvard, who is one of the leaders in value-based healthcare reform, has described the value equation, which describes in the numerator patient-relevant outcomes and in the denominator the costs needed to achieve these outcomes. So through the use of PROMs and the maximization of patient-relevant outcomes, we can in turn significantly increase patient value. So what makes a good PROM? So a good PROM is valid, measuring what it claims to measure, is reliable, demonstrating consistency in this measurement, and is responsive and sensitive, able to detect meaningful change over time, even if small. So traditional or legacy PROMs in spinal surgery that possess these qualities are listed here and are traditionally called, referred to as legacy PROMs. So through their extensive use, some shortcomings have been established for the use of PROMs. So the lack of patient engagement, patient question fatigue, and time required to perform these questionnaires, cost to perform, and also limitations in health literacy. So in an attempt to mitigate these shortcomings, a group at the NIH in 2004 developed PROMIS. So PROMIS has unique utilization of item response theory. So this is a form of adaptive computerized testing that has been used in standardized academic testing, such as the SAT, for some time, but is relatively new in the field of medicine. This allows for the generation of better answers with fewer questions. It has been demonstrated to arrive at an accurate measure after as little as 4 questions. PROMIS uses a very large item bank of over 20,000 questions. It's been translated into over 33 languages and is free to use and has shown improvements in validity, efficiency, decreased patient burden, and lessened ceiling and floor effects, and also smaller sample size requirements. So previous studies have demonstrated PROMIS physical function utility in cervical spine surgery. However, information regarding its long-term validity was lacking. So here are a few papers that examined PROMIS physical function among cervical spine patients. And so our study worked to address the question and to evaluate PROMIS physical function correlation with the legacy PROMs already in place and assess its long-term validity at 2 years among patients undergoing ACDF surgery. So a prospectively maintained single surgeon, single institution database was retrospectively reviewed for ACDF patients from May of 2015 to September of 2017. Inclusion criteria included primary elective single or multi-level ACDS for degenerative spinal pathology. Mean scores of preoperative and postoperative time points were calculated for VAS neck, VAS arm, NDI, and short form 12 physical component scores. So those are the legacy PROMs which we would be comparing PROMIS physical function with. So for our results, with respect to scoring, and the NDI and the VAS neck showed significant improvements over time. Also, VAS arm showed significant improvements over time, except for at the 2-year mark. Short form physical component score also showed improvement in the different time points, except for the 6-week mark, and similarly seen among PROMIS physical function scores, where significant improvements are seen, except for the 6-week mark. This could be due to a large proportion of myelopathic patients in this cohort, where the return of function within that early 6-week period was delayed. So with regards to each legacy PROMs correlation with PROMIS, we see strong correlations with NDI and short form 12 physical component scores. So between NDI and short form 12 physical component scores, we see strong correlations at all time points. With VAS neck, we see strong correlations with PROMIS at all time points, except for the preoperative period. So here we see a visual representation of the correlation of PROMIS and legacy PROMs in our study. So at each time point, we see a repeating pattern displaying consistency in that correlation with PROMIS. So at each time point, we see a positive correlation with PROMIS and the legacy physical function measure on the right side of the right y-axis. And then we also see a repeating negative correlation between PROMIS and the neck disability index, which is on the left, at each preoperative 6-week, 12-week, 6-month, 1-year, and 2-year time points. So in conclusion, PROMIS PF is strongly correlated with pain disability, and physical function at up to 2 years for patients undergoing ACDF. So our findings support the long-term validity of promised physical function for the measurement of physical function in patients undergoing ACDF. So future directions. So future directions include the use of big data to construct spine registries where machine learning can integrate subjective and objective data to better track patient characteristics, function, and outcomes. An area of investigation is in the use of cellular accelerometers, which is being studied here at the University of Miami with Dr. Wang, Dr. Basil, among others, and also being examined with Dr. Komatar with patients suffering from normal pressure hydrocephalus and tracking their movement patterns. Also, investigations into the role of patient expectations and patient reported evaluation of outcomes could be of value, and also investigations into the potential use of game theory to improve engagement in these surveys could be of use. So acknowledgements, I want to thank everyone who assisted me with this project and allowed me to conduct this research. And also I have my references listed here. So that concludes my talk. If there are any questions.
Great job.
Thank you.
We got Henry Chang next.
Yes, sir. David, can you stop sharing your screen so I can?
Yes, absolutely. I will. There you go.
Thank you so much.
Thank you all.
So hello, everyone. Thank you for having me here today. My name is Henry. I'm one of the sub-interns on the team. It's an honor to be able to present today. So thank you for including me into this grand rounds. It's been a pleasure listening to some of my co-subs present as well. Today, my talk will be entitled Safety and Facial Nerve Outcomes of Intracisternal Papaverine Irrigation Progressive Schwannoma Resection. So just some brief background, papaverine is a vasodilator, works through calcium channel modulation. And papaverine has clinical utility and has been used in cases such as erectile dysfunction, treatment for frostbitten digits, cardiac bypass surgeries. But in the interest of neurosurgery, it's used to prevent or treat vasospasms in treatment surgeries for aneurysms or tumor resections. And then, at least in the context of this discussion today, the thought is that papaverine can help vasodilate small arteries supplying facial nerve in the context of vestibular schwannoma resection, therefore possibly preventing ischemic complications. Of note, the literature has documented some adverse effects with papaverine, including hypotension, cardiac arrest, and cranial neuropathies. But nonetheless, the question remains, safety and the overall facial nerve outcomes during intracisternal papaverine irrigation, vestibular schwannoma resection, which is the aim of our study. So what we ended up doing is retrospective review of cases of vestibular schwannoma resections between 2008 up to 2021. These cases were all conducted by Dr. Morkos as head surgeon with several neuropathologists. They utilized a couple various approaches, including retrosigmoid, middle cranial fossa, translabyrinthine, and rarely but did occur the extended combined petrosectomy. And what we ended up doing is patients were under neuromonitoring, and in cases where they demonstrated changes in neuromonitoring, such that the stimulation threshold for facial nerve response rose above 0.05 milliamps, indicated, or in our case, would indicate use of papaverine. We defined the stimulation threshold as the threshold necessary to first evoke a response from facial nerve of at least 100 microvolts. And so we compared those patients with patients that did not have neuromonitoring changes, thus they did not receive papaverine, and that constituted our control cohort. We took note of the House-Brackman grading, final facial nerve stimulation. This is after resection, and complications, should they occur, were documented as well. So our results, to put this all together, we note that in the interest of time, roughly all the baseline characteristics were same between both cohorts with no statistical significant difference. However, the two areas I want to point everyone's attention to is fundal cap was more likely prevalent in the papaverine cohort, which was statistically significant. And then for the craniotomy approach, for the papaverine cohort, more likely to undergo a retrosigmoid approach compared to non-papaverine cohort. Now, I'll discuss more about this in a little bit as well. As for outcomes, well, immediately post-operative, we on the left have a figure demonstrating kind of distributions of House Brackman scores. And it was noted to be on Mann-Whitney that the papaverine cohort was more likely to have improved facial nerve outcomes, at least based on House Brackman documentation. The mean, I believe, was around 1.5 compared to the non-papaverine cohort, which was roughly around 1.9. The distributions are displayed right here. And then on the other hand, we also dichotomized outcomes of facial nerve between House Brackman 1 or more than one, essentially either asymptomatic or symptomatic. And on regression, we can see that those that receive papaverine intraoperatively was less likely to be symptomatic facial nerve. That was statistically significant. And then when we dichotomized between 2 and more than 2, it showed a trend at 0.059. However, it failed to reach statistical significance. And importantly, at 6 months, 1 year, and that final follow-up, there's no significant difference between 2 cohorts. I also want to point everyone's attention to the bottom of that table on the right. We can see that post-resection facial nerve stimulation threshold between the two groups was not statistically significant. This is a post-resection, so not the intraoperative resection neuromonitoring changes that indicated indicated papaverine use, but post-resection. And I'll talk a bit more about that as well later. Just another graphic representation of the outcomes immediately post-operative. Lower House Brackman grades on the papaverine cohort, statistically significant, but as you proceed on to 6 months, 1 year, and last follow-up, no significant difference between the two groups. And then, so those were unadjusted results. The question remains, of course, based on the baseline differences, could there be some degree of confounding, especially on the presence of tumor fundal cap and surgical approach? Well, to assess that, we started by just kind of, assessing for associations between these variables and post-operative House Brackman grades, at least on non-parametric exam or non-parametric analysis and ordinal logistic regression. Interestingly enough, they were not associated post-operative outcomes. Nonetheless, we fit a multivariate model with papaverine and these 2 factors, and the results remain stable. Papaverine significantly associated with improved facial nerve outcomes. Those are adjusted odds ratio at the bottom and the p-value. And then to take it a step further, we took all baseline demographic variables, and under univariate regression, we kind of looked at the associations between those variables and post-operative outcomes. 3 variables were deemed to be significant, were at least significantly associated with House Brackman grades post-operatively for facial nerve. That was tumor volume, preoperative House Brackman scores, and then the stimulation threshold, which is what discussed just a moment ago, the post-resection facial nerve stimulation threshold. Fitting papaverine use into a multivariate model incorporating these 3 significant variables, and furthermore, with all variables regardless of association, results still remain stable. Adjusted odds ratio displayed at bottom, 0.4 ranges from 0.41, 0.45, p-values displayed as well. And then as a final thing, to kind of capture a global picture of everything, we conducted a propensity score matched analysis through a 1-to-1 greedy non-replacement match. We were able to get 41 match cases for each of the 2 cohorts. Post-match variables are displayed here on the table, no difference between the 2 groups. And afterwards on ordinal logistic regression and Mann-Whitney, we can see that papaverine use and post-operative facial nerve outcomes, our results remain stable. It was associated with improved facial nerve outcomes. Regarding complication rates, which was the second half of this project that we wish to talk about, complication rates, you can see not statistically significantly different between the 2 groups. And then I mentioned earlier that hypotension and some cardiovascular complications has been documented in the literature. Actually, we did not observe that in our papaverine group. The 4 cardiovascular complications occurred in our non-papaverine cohort, 1 STEMI, 1 DVT, and 2 pulmonary embolies, none of which occurred in the papaverine group. Of note, however, there was 1 hemorrhage in the papaverine cohort. It was a bleed into the resection cavity. I believe the patient did eventually require an EVD, I think on post-operative day 3, ultimately weaned without need for permanent CSF diversion. But aside from that, 5 cases of infection and then 9 cases of CSF leak. So what does this all mean? Well, at least in our modest little case series analysis here, we can see that for intracisternoid papaverine irrigation appears to be safe. At least it yields comparable results immediately postoperative, similar long-term between the two cohorts. I previously pointed out that the post-resection facial nerve stimulation threshold was not different between two groups. That was actually an interesting result for us because pattern use was indicated in the cases with neuromonitoring changes. So it was interesting that post-resection nerves were, I guess you can say, almost equalized or normalized between two groups without significant difference. And then, of course, our analysis, at least based on documented complications, pattern mitigation seems to be safe with no increase in complication rates. But of course, with all studies, there are limitations. For ours, we lacked a true control group in the sense that while we had a comparative group that did not receive papaverin, those individuals also did not experience neuromonitoring changes intraoperatively, which is what indicated the use of papaverin in our first group. So perhaps a more appropriate control group would be one that, despite neuromonitoring changes, didn't receive papaverin, or even if in absence of neuromonitoring changes, the papaverin was irrigated over nerve as well. And then furthermore, of course, there's a retrospective analysis, so there's some degree of confounding that could have slipped in, maybe perhaps like occultly and undocumented. We noted improvements in facial nerve immediately, but then no long-term differences. This could be explained by perhaps a number of undocumented factors that we might have seen on chart review or in the documents. And then, of course, propensity score matching, we only yielded 41 matched patients. Might imply that underlyingly there's some degree of difference between two cohorts that, had they been more equal, we would have yielded a higher match group. And then, of course, a prospective trial will be the gold standard moving forward, and perhaps could corroborate our results or even elucidate further associations between papaverin complications and facial nerve outcomes. And that concludes my talk. I just want to thank everyone for the opportunity to present today for rotating the department. It's an incredible experience. I've learned a whole lot, and I'm ready for any questions. Thank you.
Coming up next, we got Dr. Efrat. Dr. Efrat, if you can hear me, you can share your screen.
Yes. Good morning.
Good morning.
Share my screen. Hold on.
Hey, Efrat, thanks again for doing this. Really appreciate it. For those of you who don't know Dr. Efrat Saraf-Levy, she is one of our senior neuroradiologists who's a real expert in peripheral nerve imaging, and super appreciate you doing this.
Okay, thank you, Dr. Levy, Dr. Landy, for inviting me to speak this morning about imaging of the brachial and lumbosacral plexus. So just a few points. The technical advances in MR imaging have resulted in improved diagnosis and evaluation of the peripheral nervous system, and have an important role in the evaluation of peripheral neuropathy and plexopathy. With the newer and more sophisticated microsurgical procedures to repair damaged nerve comes the need for non-invasive techniques that improve the diagnosis accuracy of peripheral neuropathy and facilitate preoperative planning. Electrophysiological studies that are often used, they have high sensitivity for detecting a conduction abnormality, but they lack specificity and cannot display the anatomic details needed for precise localization and treatment planning. So how do we do these studies? To obtain highly detailed images of peripheral nerve, we use specialized radiofrequency receiver coils. They are called phased array coils. These phased array coils, the technology integrates signal data from multiple small coils to produce a single image mimicking a single larger coil. The radiofrequency signal from each small coil is collected independently of the other coils in the phased array, and each contributes signal from a small field of view with a high signal to noise ratio. So by combining the signals from the multiple small coils, an image can be produced that has a high signal to noise ratio of each small coil with a field of view similar to that of a single larger surface coil. The image produced from the phased array configuration is thus markedly improved relatively to the image produced by using a single larger surface coil or a whole body coil. The assembly is flexible and can be shaped to fit curved contours of the body in regions such as the side of the neck and the supraclavicular area. So you can see here that we use to image the brachial plexus. We don't have a dedicated coil. So we use like the neck coil. We use a surface shoulder coil and a body coil, and all together, you know, they combine to give us a high resolution image. Sorry. The basic unit of the peripheral nerve is the axon, which may be myelinated or unmyelinated. And isolated peripheral nerves in the extremities, as well as nerves comprising the brachial and lumbosacral plexus, are a mixture of such axon. The largest peripheral nerves have 3 connective tissue sheets that support and protect the complex. A schematic drawing of peripheral nerve anatomy. You can see the fascicles with the, within the large peripheral nerve. They are interspersed with variable amount of adipose tissue and surrounded by epineurium. Each fascicle is enclosed by a ring of dense perineurium and contains myelinated and unmyelinated axon, supported by loose entoneural connective tissue. You can see the image on the right with the arrow is an axial fat suppressed T2 weighted image of the sciatic nerve. And it shows these dots are actually showing the fascicular pattern. The fascicles display a honeycomb-like appearance of hyperintense signal, and there is interspersed adipose tissue and connective tissue, which is the more darker areas in the nerve. So this technique provides reliable images of peripheral nerves measuring at least 2 to 3 millimeters in diameter. This includes the nerves of the brachial and sacral plexus. So we do the MR evaluation of peripheral nerve in 2 ways. The first and most important way is by direct high resolution imaging of the nerve. And the second is by imaging of the major muscle groups that are innervated by these nerves and looking for changes in signal intensity indicative of denervation. So you can see here, this is an image of the sciatic nerve on T1 weighted image, and it shows the size and location of the nerve. In some cases, all or part of the course of the nerve may be obstrued by surrounding muscle tissue because of lack of intervening fat. And in these cases, I rely on comparison of the T1 and T2 images to trace the course of the nerve and to monitor its appearance. So you can see the normal nerve is oval or round. The size of a particular nerve, such as the sciatic nerve, varies along the length from person to person, but in the same person, it should be the same on each side. So that is helpful to compare between the 2 sides on a specific patient. The rod-like fascicle within the nerves are visible on high-resolution cross-sectional images seen on end. The collection of fascicle within the nerves has a honeycomb-like appearance called a fascicular pattern. And the fascicles, they should appear uniform in size, and generally they are mildly hyperintense relative to the adjacent muscle on T2 weighted images. So comparison between T1 weighted images and FastSupra and FastPineco T2 images is helpful in confirming the size and location of the nerve. So you can see here, it's pointing to the sciatic nerve on this side. This is a normal appearance of the nerve. And you can see on the other side that the nerve is enlarged. And as I mentioned, on T1, the nerve is usually isointense to muscle. On T2 weighted images, the fascicle within a normal nerve are mildly hyperintense relative to adjacent muscle tissue. In cross-section, the fascicular pattern is more easily discernible on T2 weighted images than on corresponding T1 weighted images. So you can see here, again, here's the normal nerve, and here's the abnormal side. And on T2, you can see this fascicular pattern, it should be uniform. But here you can see it's both very hyperintense and also the fascicles are not uniform. So this is abnormal. An altered fascicular pattern is another finding indicative of abnormal nerve besides the size. All right, so what technique do we use? So in order to image the brachial plexus because of its orientation, the in plane is actually coronal images, and the cross-sectional of the brachial plexus specifically is the sagittal images. So we use this both a small field of view focusing on the brachial plexus, but we also use a large field of view to compare to the other side, because it's a little bit difficult to decide when you see the intensity on T2, it's hard to decide if it's normal or abnormal. You have to compare it to the other side to be kind of more sure if you're calling abnormally hyperintense signal. One more important thing is we obviously do the pre and post contrast T1 and the T2 image. And the important thing is that we co-register them, meaning that there will be each sequence will be exactly at the same location. So then when I go and compare the T1 to the T2, I can be sure that I'm in the same location. So that's very important, co-registering it. So this is a schematic diagram of the brachial plexus with selected vascular and scale landmarks. You can see here that the plexus is above the subclavian artery and behind the subclavian vein. And we use like these different planes of imaging. So you can see the 5 roots of the plexus, C5 to T1 ventral rami. Plane A is the interscalene triangle plane, where you can find the brachial plexus trunks. Plane B, once they come out of the interscalene triangle, these trunks divide into 2 divisions. So you can find the divisions here. And then on plane B, these divisions form the cord. So the divisions are anterior and posterior, and each division, the 2 divisions form the brachial plexus cord. And you can see in the level of the coracoid process is plane C. You can see these cords branch into different branches. So this is just to say that the lateral cord is the anterior division of the upper and middle trunk. The medial cord is the anterior division of the lower trunk, and the posterior cord is the posterior divisions. So here's the T1 coronal image, and the arrows are pointing to these 3 planes that I discussed, and this is just a corresponding anatomical image to see the relative size of the plexus to the subclavian artery. We cover with the coronal images all the way to the coracoid process, which is here. And if there is an interest in imaging the branches of the plexus, then you need to get a shoulder MRI. So this is the sagittal image at the level of the interscalene triangle. So you can see this is the anterior scalene muscle, this is the posterior scalene muscle, and this is the interscalene triangle. Sorry, at the bottom of the triangle is the artery. This is the subclavian artery. And now you can see all 5 roots of the plexus, 5, 6, 7, 8, and T1. The vein is like anterior to the triangle, and this is just a clavicle. This is the anatomical specimen showing corresponding image to this. So you can see that we can see very well on the sagittal images and follow the different components of the plexus, and actually use more the sagittal images for that purpose. So in some patients, when there's not a lot of fat, I mainly use the T2 images, and you can see that these components of the plexus, as I said, they're a little bit hyperintense, but they should not be as hyperintense as the vessel. So that is also helpful in addition to comparing it to the other side. So you can see here we're at the level of the interscalene triangle. You can see the subclavian artery at the bottom of the triangle, the muscles, and these are the three trunks of the plexus, the upper, middle, and lower trunk. This is already at the level of the divisions, and you can see the subclavian artery at the bottom here, and superior to it is the divisions of the plexus. So you can see that we can very nicely image the different components of the plexus. This is plane A, and this was plane B from the diagram that I showed before. Okay, so what are the indications for plexus imaging? Mass involving the plexus, traumatic injury, nerve entrapment or compression, plexopathy, neuropathy, and post-treatment evaluation. So I'm going to show example of each one. This is an example of a mass involving the plexus. It's a 78-year-old woman with 1 year history of progressive burning in the left upper extremity. So you can see here the imaging of the left brachial plexus, T1, stir, and the T1 post-contrast with fat suppression. Just to mention that on specifically the brachial plexus, we use a stir and not a T2 fat suppression technique because of all these different soft tissues. We don't achieve good fat suppression with the T2 fat suppression, so we use the stir for that purpose. It's better. So here you can identify that along the course of the plexus, you can see this lesion. On T1, it's hypointense. It's hyperintense on stir and it enhances. It's very well defined. And you can see on the sagittal images, so we're at the level of the cords. So you can see the subclavian artery at the bottom. And then I know anatomically that these cords are arranged in a clockwise fashion. So this is the lateral cord, this is the posterior, and this is the medial cord. So I'm able to identify that this mass is involving the posterior cord. So this was the mass in the posterior cord. You can see here, like, as I said, it's very low on T1, high on T2, and enhances homogeneously. And this is like typical appearance of a schwannoma. This is another case of Panco's tumor. You can see it's in a 60-year-old woman. These coronal T1 weighted images show small bilobe mass. You can see the white arrow is pointing to it in the left lung epi. And you can note that there is preservation of the normal interscalene fat pad, which is pointed by this black arrow, big black arrow, which on coronal images has this triangular appearance. So you can see that this mass actually did not involve the brachial plexus. We often get patients with Panco's tumor for evaluation of involvement of the plexus. And in this case, you can see how nicely it shows that it's not involved. Another indication is traumatic nerve injury. So there are three mechanisms of injury. A is traction, where it's actually stretched. B is percussion, when there is a direct blow to that area. And C is cervical nerve compression, where it's kind of like compressed between the spinous process and the clavicle and the first rib. So this is an example of A, which is this stretching of the plexus that resulted in nerve root avulsion and traumatic meningoceles. So you can see here, this is the meningocele. You can have avulsion with meningocele, you can have meningocele without avulsion, and it's most common at the C7, C8 level. You can see here, besides this pseudomeningocele, you can see that there is this, I'm pointing to this kinking, because in this case there was an avulsion, and it's like a, because it was a valve, it kinks and it has like this appearance, and it's not nice, straight and smooth like I showed you on the coronal image previously. So it's a little bit difficult to say with MRI if the avulsion is complete. There may be some rootlets left that are intact that possibly are giving some functionality. So another indication is nerve entrapment compression. And in the case of the brachial plexus, we're talking about thoracic outlet syndrome, the neurogenic one, because there is also vascular one, which we image in different ways, more vascular imaging. And thoracic outlet syndrome happens when there is insufficient space for the nervous structures. And a lot of these times there is some congenital anomalies with a superimposed injury. The symptoms may vary, and it's divided into upper and lower plexus thoracic outlet syndrome. So this is this article that was going into this details of like what types of thoracic outlet syndrome there is. I'm not sure we can be that, precise with this evaluation. Like in this article, I can say that I saw every single case here that is described, but if you're interested, you can look into this article. So this is a case of a cervical rib. So you can see the rib here on X-ray, and then on this T2 image, you can see it here. And if we look at the sagittal images, you can see this is the interscalene triangle, remember? And this is the artery, and that's the plexus. And you can see the rib here. It's kind of like there's another band coming out of it, and it goes right through the plexus. You can see the trunks here and goes right through them. So this was causing the patient's symptoms. I have to say that it can be very challenging to diagnose this, especially when you're looking for a fibrous band. So this is a case that of Dr. Levy that on imaging, I could see that there is some deformity here. It's usually the first hint that there is something there. And I could see something coming out here like that was like low in signal. And this is the sagittal image, and I can see it here again. So I thought it most likely represent a fibrous band. And this is images that is from surgery. And Dr. Levy actually invited me to go into the OR and see that this band was identified in the location that was shown on the images. And here he's cutting this band. And I think that this patient did better after surgery.
They did.
Okay, so then the other indication is unexplained Taxopathy neuropathy. So this is a 54-year-old man with left-hand motor weakness following a long surgery for retrosternal goiter resection, where her arm was positioned above her head for 6 hours and they didn't move it. So she woke up with some weakness, and then we did this imaging, and you can see that this high signal in the plexus. You can see that it involves mainly the lower trunk. And so this is an example of stretch injury. Typically these patients may recover from it, or usually actually they recover from it, but it takes like some time. So I think in this case, we imaged her later on, and the signal abnormality resolved. This is another case. You can see this is an 18-year-old woman, and you can see this diffuse thickening of the brachial plexus. There's also hyperintensity to signal, and this is one of these hereditary hypertrophic neuropathy, Charcot-Marie-Tooth disease. Another example of a 27-year-old woman with a 2-year history of progressive right arm weakness, numbness, and pain. And you can see again the same thing, this diffuse thickening of the plexus. And if we look at this plane and look at the sagittal images, you can see these roots are hypertrophied. So this is 5, 6, 7 to lesser degrees, not really involved, but 5, 6, T1, C8 and T1 are involved. And this is at the level of the roots. And then at the level of the trunks, you can see the upper trunk and the lower trunk are really hypertrophied. The middle trunk is actually was normal in this case. So I'm just pointing to the subclavian artery and vein, and these are the upper, middle, and lower trunk, where the involvement is of the upper and lower trunk. So this was a case of CIDP. Last indication post-treatment evaluation, especially important in brachial plexus imaging, mainly in patients with breast cancer for evaluating recurrent tumor versus radiation injury. So you can see here the arrow is pointing to this area in the brachial plexus, expected location, and you can see that there is this globe of soft tissue, enhancing soft tissue involving the plexus. And on sagittal images, we're able to identify that this actually in a form of a mass. You cannot see the different components of the plexus, and it's enhancing. So this was tumor infiltration of a recurrent breast carcinoma. This is another case that we can see this high signal in the medial cord of the plexus, and it was only involving the medial cord. And on PET imaging, you can see there was uptake. So this is another thing that is suspicious for tumor, because radiation necrosis will not just involve one component. If there is injury, it will involve all components of the plexus in the field of radiation. So this is the sagittal images showing the lateral, posterior cord, and you can see the medial cord was involved in this case by this infiltrating tumor. So as opposed to involvement by tumor, radiation injury, you can see this slight increase in size and signal intensity, but it's very diffused. You can see it's involving all plexus component. It's diffused. It's not in a form of like a mass. So this is typical for radiation injury, and so this is helpful in differentiating it from tumor infiltration. So then I'm going to move to imaging of the sacral plexus now. So how do we image it? In the coronal and axial planes. So the in plane is the coronal, and the cross section is the axial images. So the sacral plexus, you can find it anterior to the piriformis muscle. It's formed from the ventral rami of L4, L5, and S1 through S4. There is anterior and posterior divisions. And the main nerve that comes out of this plexus is the sciatic nerve, obviously. These are coronal images of a normal person. So you can see the piriformis muscle here, and this feathery structure at the level of the sacroiliac joint is the sciatic nerve. You can see, you can follow it down. So here it is on both sides. These are axial images with corresponding pathology specimen, and you can see these are the gluteal, intergluteal vessel. This is at the level of the sciatic foramen. This is the piriformis muscle, a gluteal muscle, and then the sciatic nerve. So you can see it here, the sciatic foramen, and this feathery appearance, which again is not as hyperintense as the vessels, but it's somewhat hyperintense relative to muscle. And that's the normal appearance of the sciatic nerve. The techniques that we use for the coils, we use a pelvic phase array coil. As I mentioned, the in plane is the coronal plane, and the cross sectional is the axial plane. We'll use high resolution, high matrix imaging, and again, co-register all the images, so we'll be able to do direct comparison between the T1 and the T2 and the post-contrast images to detect abnormalities. So again, same indications more or less as I mentioned, the brachial plexus. We'll start with a mass involving the plexus. So these axial images at the S4 level, And you can see this, there is a soft tissue involving the sciatic nerve. You can see the normal sciatic nerve on the other side, and obviously you can see this mass involving the nerve. And here at the level of the sciatic foramen, again, the piriformis muscle, you can see the sacral plexus is here. And on the other side, you can see that there is a mass involving the plexus. Also, another thing that I mentioned to you before is we look for denervation changes. So here it is, this atrophy of the gluteus muscle. So there were denervation changes here, and this was a metastasis. This is another case. Again, coronal images. Here's the sciatic nerve on this side. She presented with product pain. And on the other side, we see this mass. And we can see this mass is continuous with the sciatic nerve. So it's a mass involving the sciatic nerve, very low on T1 and very well defined. And this is the axial images on the same person showing the plexus on this side. Here it is. And the mass, which is low on T1, high on T2, and was enhancing this post-contrast images showing enhancement. And this was a schwannoma involving this sacral plexus. So this is another case that we saw, and you can see here that in the presacral fat where the alpha or the lumbar sacral trunk is, you can see this mass. So is it a tumor? Well, you can see that this honeycomb pattern. So usually tumors do not preserve the fascicular pattern. It kind of destroys it and looks like a mass. So this is not really a tumor. And you can see it here again. Here's the sciatic nerve. You can see that there is some thickening and high signal. This was another case of hypertrophic neuropathy. So you can see how this high resolution image help us differentiate between a mass and other etiologies involving the plexus. Nerve entrapment and compression in the case of the sacral plexus, we are talking about piriformis syndrome. So this is an article that just came up with this idea of doing this 30-degree orientation to image the course of the sciatic nerve relative to the piriformis muscle. So you can see that there is anatomical variation in the course of the sciatic nerve. It can go through the muscle, in between the muscle. It can go through it can split, between the different component of the muscle. And so when we image it in this technique with this 30-degree orientation, so you can see here, this is the piriformis muscle, and you can see this is a normal course of the sciatic nerve, superficial to the muscle. So that's the typical anatomy. But in some patients, there is a congenital, abnormal course of the nerve where you can see that it splits between the two parts of the muscle. So here's the nerve, and here's where it split and goes through the muscle. So that's the atypical anatomy. You can see it here. And so in these cases, the sciatic nerve component passes through the tendon, and on internal rotation, the muscle is stretched and it's causing compression of the nerve. So it's another way of diagnosing or confirming piriformis syndrome. Post-treatment evaluation. So like I showed you in the case of the brachial plexus, this is a 39-year-old woman with bilateral lower extremity weakness and history of radiotherapy for cervical carcinoma 3 years prior to this MR. And you can see that here's the plexus, and here it is, and it looks like slightly thickened and uniformly hyperintense. And again, on coronal images, you can see again the same finding. There is some diffuse thickening and hyperintense signal, and it's another case of radiation injury. And lastly, lumbar plexus. So the lumbar plexus is actually along the psoas muscle. It's formed by the ventral rami of L1 through L3. Sometimes there is contribution from T12 and L4. There's like two divisions, anterior and posterior. And the main nerve that we image is the femoral nerve. So this is an indication for evaluation of either the plexus or the femoral nerve. As far as the technique, we're using the spine coil, the cervical thoracic lumbar spine array. Again, the views are, the coronal is the in-plane and the cross-sectional is the axial images. And we also do, in these cases of the lumbar plexus, we also do sagittal images of the lumbar spine. That's included in our protocol. Again, high resolution images, and we co-register all these images. We use T2 fat suppression. The only time when we don't use the T2 fat suppression, as I mentioned, is in the case of the brachial plexus, because we achieve better fat suppression with the stair technique. So again, examples. This is a very interesting case of traumatic nerve injury. So you can see here the axial T1 and T2 fat suppression images at the level of S1. You can see the femoral nerve is right here. And here's an example of what I mentioned before, that when it's close to the muscle, it's very hard to see where it is on a T1 weighted image because it's iso-intense to the muscle. However, when we look at the T2, we can see it because it's slightly hyper-intense. And if you compare it, you can compare it either to the vessels, and you can see that it's not as hyper-intense as the vessels, or you can compare it to the sciatic nerve, which is, or the L5 root, which is here, and you can see it's similar intensity. So in this case, this is the normal appearance of the femoral nerve. However, if I go distally, so this is at the S5 level, and you can see that the femoral nerve is in the groove between the psoas muscle and the iliacus muscle. And in this case, you can see that this nerve is enlarged, and it's also hyperintense. So this was from traumatic injury to the femoral nerve. This is to show the atrophy and hyperintense signals. So this is what the innervation changes in the quadriceps muscle group look like. You can see it here. And so that was femoral nerve denervation changes. So you can see how it helped us in, making this diagnosis, the abnormality in the nerve, and then the denervation changes. It's another interesting case of Dr. Levy. This was a 29-year-old police officer with worsening back pain radiating to the right hip and right lower extremity paresthesias. So you can see here, there's images of the lumbar plexus, and you can see that there is these multiple lesions involving the roots of the plexus. You can see it here, and also on the axial images, you can see that as well. So it was in multiple levels. Interestingly, when we gave contrast, there was barely any enhancement. So this was very puzzling case, because initially we thought maybe it's nerve sheath tumors because there was multiple lesions. However, upon, further digging into her history, we found out that she fell from 5 feet 3 years ago. And so this is actually a typical appearance of lumbar plexus traumatic neuromas, which is not really like a tumor, but more like kind of like disorganization of the nerves in an attempt to try to repair the nerve that was torn or injured. So, and typically in this patient, it looks like nerve sheath tumors, but the key is the history and the fact that there is relatively lack of enhancement, which was supportive of this entity in this case. So in summary, we use the high resolution images of peripheral nerve in treatment planning by peripheral nerve specialists. It can help decide the need for biopsy or surgical treatment. It helps in planning of surgical approach, prognosis for preservation of nerve function. And in cases of trauma, also the likelihood of spontaneous recovery versus the need for surgical repair, and also to monitor progression of nerve recovery. So thank you very much again for inviting me. And I would like to know if anybody has any questions about imaging of the plexus.
Thank you, Efrat. That was awesome. Have a good one. Thank you.
Thank you.